Hello, this is Jonathan Edelheit, Editor-in-Chief of the Healthcare Reform Magazine in the Employer Healthcare and Benefits Congress. I'm here today with Ben Conley from Safe Farth Shaw LLP, and we're here to bring you a webinar entitled Healthcare Reform Update, New Guidance from HHS, the Department of Labor, and the Internal Revenue Service. So this webinar will address the amended rules regarding plans offering incentives and penalties and wellness programs, including the special rule for smoking cessation wellness programs, new guidance on essential health benefits offered through the exchanges, and cost-sharing limits in plan design, including limits on deductibles and out-of-pocket expenses, ensuring your plan provides minimum value. So we're really excited to be the first in the industry to bring you this cutting-edge webinar on this topic of the new rules and guidelines that were just released very shortly and recently. And whether you're an insurance or HR professional, understanding what healthcare reform, where it's headed, is going to be critical to success and survival. It can be difficult to not only stay on top of these things or even have time to read about it, let alone interpret and understand proposed rules and guidelines. And I think as more rules and guidelines are pushed forth since President Obama's re-election, we're going to see more of that happen, where the HHS, IRS, and the Department of Labor are going to start pushing forth a lot more rules, guidelines, interpretations. It's going to be very difficult for all of us in our day to take time out to really read these and figure out what these mean. So, we're really excited to be able to bring you this content, kind of summarize it in plain English. So this year is going to be a very important year. I think everyone's going to have to stay much more on top of it before, since the main deadline for most of the major impacts within healthcare reform starts January 1st, 2014. More of these things that come up, you're going to have to stay on top of them way in advance, and I don't think you're going to have very many resources out there that are really going to educate you. So I'm really excited. This is one of our big webinars. We have over 1,000 people that register for our webinar today. So just before we go into some of the content regarding the webinar, I just want to share with those of you who aren't aware, whether you're certifiable or not, we launched our Certified Healthcare Reform Specialist designation about 2 months ago at our 4th Annual Employer Healthcare and Benefits and National Healthcare Reform Conference. All the instructors are the top national experts, academics, lawyers in healthcare reform, and we've actually, besides the first couple hundred people that are going through certification now, both human resource and insurance professionals, we're doing and have done our first group certification, where employers and agencies and consulting firms, we put together special packages and are doing them as private groups, either online or in person. The course is about 8 hours. It has 8 modules. It covers a comprehensive topic. We have a workbook for it with a 100-question exam, and we're going to be coming out with an actual textbook for it very shortly. One of the biggest things within the certification that we've developed is promoting those who get certified. So we've actually launched the search functionality on the Healthcare Reform Magazine website, and it's going to be on our conference website too, where if you click on it, you can search across the country for those HR and insurance professionals who have been certified, and we're going to be publishing those people in our magazine and also in our Healthcare Reform LinkedIn group, which has over 13,000 members. And that's an example, just a screenshot of where people can search actually anywhere in the world but by country and list and actually contact those people who have been certified. So for a legal disclaimer, all of you can read this. This is just that we're not giving any legal advice, and you should always consult your attorney with regard to this webinar. So with that, I would like to turn over the webinar to my co-host, Ben Conley, who is a top national expert in healthcare reform and an attorney. So Ben, on to you.
Thanks very much, Jonathan. And for those of you that are following healthcare reform closely, it's been a rough winter, and it's only going to get worse, unfortunately. As you've seen, we've had a slew of guidance that has rolled out over the last couple of weeks. And I was just on the phone with an agent from the DOL yesterday who said that if you're going to take a Christmas holiday, do it now, because come the end of the year, there's going to be even more regulations released. So just get ready, and it's tough to stay on top of, but that's why we're here, is to try to help you all out. So here's a roadmap of what we're going to look at today, and these are all regulations that have been released within the last month. So this is all brand new material, fresh off the presses. We encourage you to go read the regulations yourselves. Of course, there are thousands and thousands of pages just for these discrete provisions, so we're going to provide a quick high-level summary of what's happening. Okay, so the first set of regulations that were released were related to wellness plans. And so to orient ourselves, we just want to give a quick overview of the general structure regarding wellness plans and the laws that relate to those plans. So HIPAA already regulated the use of incentives and penalties in wellness plans. This is nothing new. The Affordable Care Act did make changes, though, and that's what this chart shows. Generally speaking, there are two types of wellness plans. There are participation-only wellness plans, which you see running down the right-hand column here, and then there are health standard wellness plans, and those are wellness plans where to achieve the incentive, the individual has to either achieve a certain goal, take a health risk assessment, achieve a certain BMI, quit smoking, things of that nature to achieve the goal. So it's really important to distinguish first whether the wellness program you're dealing with is a participation-only wellness program, where they only have to show up or do some opt-in, opt-out activity, or a health standard wellness program where they have to achieve a specific standard. So if you have a participation-only wellness program, the only real rule is that it must be similarly available to all similarly situated individuals. So not a lot of standards apply in that context of participation only. For health standards, though, there are some more specific requirements that apply, and you can see the 5 big ones below. First, you have to provide a reasonable alternative for people who cannot achieve that standard. Second, you have to provide employees of a notice of the availability of that reasonable alternative. You have to provide the individuals with the opportunity to qualify for that incentive or avoid that penalty at least once per year. There is a general limit or threshold in terms of the amount of penalty you can assess or the amount of reward you can give. And finally, the wellness program shouldn't be a subject for discrimination. In other words, you can't just use this to force the people out of your plan who are high-cost individuals. It has to be specifically designed towards achieving a certain wellness objective. So there were a lot of changes in the rules, but there are 2 big ones that we're really going to focus on. First is the notice that you're supposed to give individuals to notify them that, yes, here's our wellness plan, this is how it works, but if you can't achieve this standard, you can apply to have a reasonable alternative that you can achieve instead to get their reward. And the second is the limit on incentives and penalties. So previously, under the prior rules, any penalty or incentive offered under a wellness program could not exceed 20% of the overall cost of the coverage. Now, when we say overall cost of coverage, what we're talking about is the fully loaded COBRA rate, or for purposes of a fully insured plan, the full premium that the health insurer is assessing to the employer. So when you look at that whole rate, not just the portion of the employee's paying, the amount of the penalty or the amount of the incentive can't exceed 20% of the overall cost. So let's take a $1,000 plan, a plan that has a premium of $1,000. If let's say you have a standard-based wellness program, remember we're only dealing with standard-based wellness programs here, that requires employees to quit smoking. So, otherwise, they have to pay an extra $200. That $200 is the outside range of the threshold of how much you can incentivize. You can't incentivize $500 because that would exceed that 20% threshold, and that's related to that standard. Now, that was under the new rules. Under the old rules. Under the new rules, the thresholds actually increase starting in 2014, and the amount of the increase is indicated by the type of wellness program you're dealing with. So if you have a wellness program that relates to anything other than smoking cessation, so you've got something like BMI or things of that nature, cholesterol or blood pressure or things like that, the penalty cannot increases from 20% to 30%. So the penalty can't exceed, or the incentive can't exceed 30% of the overall cost of coverage. On the other hand, if you have any element of that program that is related to smoking cessation, that can bump up the penalty all the way up to 50%. But to the extent you have a combined penalty or incentive, so you've got both a smoking cessation element and a cholesterol element, the cholesterol portion, the amount of penalty that is assessed if they don't achieve that cholesterol goal, can't exceed 30%. But if you have a smoking cessation only program, you can take that incentive all the way up to 50%. Or if you have cholesterol that's 30% and then another 20% for smoking, that's also acceptable. So a lot more opportunities here in terms of wellness plan design that kick in starting in 2014. So let's give a quick example of how this works. And we already did just kind of one, but this helps put a visual to it. So let's say that you've got a plan that has a fully loaded premium of $6,000, and under current structure, the employer pays $4,500 per year, the employee pays $1,500 per year. Then you want to implement a couple of standards-based wellness programs. The first is health contingent-based, so it's based on weight, cholesterol, and blood pressure, and that is a $600 incentive. Also, you want to impose a smoker surcharge, and for somebody who fails to stop smoking or doesn't stop smoking, they get hit with a $2,000 penalty. Now, when you combine those two, this is actually okay because the total surcharge is only $2,600, which is less than 50% of the overall cost, because you see 50% would be $3,000. Put the math on the paper, because if you struggle with math like I do, you need to see it. Also, the health contingent portion doesn't exceed 30%, so you see that it's only around 10%, so that's okay too. And the two combined obviously don't exceed 50%. So that's how the new penalty thresholds will work. Now, anytime we talk about wellness, getting ahead of myself. The other thing I mentioned is that there is a new model notice that you would have to include in any, if you have a standards-based wellness program, any participant communication materials describing the program would have to include a notice to employees telling them of the availability of a reasonable alternative. And the agencies have provided a model. They previously provided a model as well, but they've now updated the model that is really intended to hit home that there is a reasonable alternative available for these employees. It's available on these slides, obviously, but it's also available in the regulations. So if you have a wellness program that includes one of these incentives or penalties, you would want to make sure that you include this in any participant communication materials describing that program. So it's hard to talk about the new HIPAA rules under the Affordable Care Act in a bubble because there are always other relevant laws that apply in structuring your wellness programs. HIPAA is the one we just discussed generally, but there are also GINA, which is the Genetic Information Non-Discrimination Act that limits your ability to acquire genetic information when you're structuring a wellness program. There's also the Americans with Disabilities Act, or the ADA, which prohibits discrimination based on health status. Now, the GINA analysis is pretty straightforward, but we're not going to get into it today. But the ADA analysis is opaque, to say the least. It's very, very difficult to figure out what the actual rule is under the ADA, and in some ways it seems to conflict with the rule under HIPAA. You could speak for 3 hours about wellness, but for purposes of this presentation, we just want to highlight that there are other rules out there. So a separate set of regulations came out at the same time as the wellness rules that addressed a number of factors, and we're going to talk about those now. First is discussion of plans that provide minimum value. And to orient ourselves, let's talk about when this comes up. As we've discussed in prior webinars, the Affordable Care Act also carries with it something known as the employer mandate. And what it generally says is that you have to either offer coverage to employees or pay a penalty. But it actually breaks down into two separate types of penalties. The first is the penalty for failure to offer coverage. If you fail to offer coverage, you could be subject to a penalty of $2,000 per year per full-time employee. You are permitted to subtract the first 30 before you calculate the penalty. On the other hand, and where minimum value comes up, if you fail to offer a coverage that is quote-unquote affordable, you could face a penalty equal to $3,000 per full-time employee who receives a tax credit or subsidy through the exchange. So this is a larger number, larger multiplier, but it's multiplied by a smaller population, fewer employees, because it's only those for whom the coverage is unaffordable. Affordable really has two meanings, and what we're going to hit on here is the second meaning. The first deals with the premium. In other words, the premium that you assess employees for the coverage cannot exceed 9.5% of any individual's wages. So that's the premium element. The second deals with minimum value. It's a plan that has to provide minimum value, which is defined as at least 60% of the health costs incurred. Now, minimum value is a vague concept, but we can tell you a couple things about it that would help out. First is there are going to be really just a couple specific benefits that you look at when you're determining whether your plan provides minimum value. And those include medical costs, hospital costs, prescription drug costs, and laboratory costs. Anything else, these are the benefits that are most frequently utilized under a health benefit plan. You could add other benefits to your plan, but it's not going to do a lot to increase your minimum value because something like acupuncture just really isn't used that much by employees, so it carries less actuarial significance when factored in the equation. So really you want to focus on those four core benefits, and you want to say on an actuarial basis that the plan on average pay out 60% of the cost when employees go to the doctor for those kind of things, or the employees required to pay more in excess of 40%, which is the most that their portion can be. Now, a couple guidelines here when you're trying to decide whether your plan provides minimum value. Generally speaking, the amount you charge the employee for the premium doesn't impact minimum value. In other words, you can move the premium up and down and it will never change the minimum value of your plan. But remember, there are two parts to the affordability test, which we discussed on the previous slide. The first deals with premium. If you change the premium too much, it might impact that half of the affordability test. The other half of the affordability test, minimum value, solely looks to the type of cost-sharing structure within the plan. So what we're talking about here are deductibles, co-payments, co-insurance, out-of-pocket limits, what benefits the plan actually offers. So it's more of a specific plan structure as opposed to the high level, what are you charging employees for premiums. Now, a lot of people are going to ask, how do I know if my plan provides minimum value? Just as a point of reference, it's estimated the average high deductible health plan covers approximately 65% of the cost of health benefit costs. So that would be a plan that provides minimum value. You're going to have to look at your plan on an individual basis, though, and certify to the IRS whether your plan provides minimum value. And there are going to be a couple ways you can do that. First, HHS, Department of Health and Human Services, is developing a calculator that will be online. You can plug in your factors, and it'll spit out a number, either green, you're above 60%, or red, you're below 60%. You can also use a safe harbor checklist if you have a very bread and butter plan, but to the extent you have unique features in your plan, which is interestingly defined as things like co-payments, which are actually pretty common in plans, but they define that as a unique feature. You may actually need to get an actuarial certification that your plan provides minimum value. Now, just to orient you, there are products being developed today that are intended to address these guidelines and provide the minimum value. So by 2014, the market is going to be flooded with plans that really hit the 60% threshold and don't provide much more, because they're really supposed to be this bare bones plan that you're offering to satisfy your requirement. So to the extent that you work with your insurer, or perhaps your broker, if you're working with a broker, that would be something that would help you to assess the value of your plan. I apologize. It sounds like I'm going too fast here, so I'm going to try and walk through things more slowly, but hopefully that provides a good overview of what is minimum value under a health plan. So what we're really talking about high level is the employer mandate. Then you focus down on the affordability part of the employer mandate. Then you focus down on just one half of the affordability test, which is, does your plan provide 60% actuarial value? And that's how you get to this determination of whether your plan provides minimum value. Okay, moving on to a separate topic. Another thing that was released in the regulations was information regarding the essential health benefits. Now, one of the frustrating things about this legislation is there are just so many buzzwords and acronyms that it's hard to keep them all straight. So let me give a high-level overview here of what an essential health benefit is under the legislation. And unfortunately, it has two separate meanings. Plans offered through the exchanges, so health insurers offering benefit plans through the exchanges, and insured plans in the individual and small group market. So any insured plan that is offered to an individual, and any insured plan that is offered in the small group market, which is generally less than 50 employees, but in some states it could range up to 100 employees. Any of those plans starting in 2014 must provide essential health benefits. Essential health benefits are a list of benefits that your plan must include. So in other words, when you go to the doctor, the plan must pay some portion must offer this benefit and must pay some portion for that benefit. At the outset, well, let me take a step back then. So that's what it means for plans on the exchanges and plans in the individual and small group market. Has a sort of separate meaning for employer-sponsored group health plans or fully insured plans on the in the insured market. So to the extent you're a large self-funding employer, or you have a plan, insured plan that covers more than 100 lives, you are not actually required to offer these essential health benefits. In other words, you can decide what benefits are offered under your plan. Now remember, we talked about minimum value a second ago, and you may be required to offer certain benefits to achieve that actuarial value level, but if you can get there some other way, you can do that. But generally speaking, you get to structure what benefits are offered under your health plan. But to the extent you do offer any essential health benefits under your health plan, which for the time being, let's just say is this list above, to the extent you do offer any of those benefits, you cannot impose an annual or lifetime dollar limit on those benefits. So you're not required to offer them, but if you do, rules apply. You can't cap the amount the plan will pay out for those benefits. Now that prohibition on annual and lifetime limits also applies in the exchanges and in the individual and small group market. But remember, those individuals, those plans in those groups, actually have to offer everything on this list. So the way that things started out, the essential health benefits was a broad list, and it's showing a few right above. And that was, generally speaking, the benefits that the legislation listed. And they said, we're going to give you a good faith interpretation buffer to determine what you think falls inside and out of this list. We're now moving towards a more structured process where they're moving towards something known as benchmarks. So previously, again, we had a list of 10 items. You got to decide what you thought fell in that list and out of that list. Now we're moving towards a more specific list. And let me talk first about how it's going to work on the exchanges, and then I'll talk about how it works for employers sponsoring group health plans. So on the exchanges, each state is going to be required to select a benchmark health plan. And what I've listed here is their options. Each state has the option of the 4 types of benchmarks listed. Now these are plans that exist in the market today and that have existed for a while, because it's the largest small group market health plan, state employee health benefit plan. These are plans that exist today, and you can look on paper and determine which plan it is that falls into these benchmark categories. So each state is permitted to choose between these 4 in selecting what will be its essential health benefit package. Once that state selects that benchmark, you can throw out that prior list of 10 items, because generally speaking, anything offered in that plan will then become an essential health benefit. So even if you have something that's very clearly not on the list above, like infertility benefits, the fact that the state has selected a benchmark that includes infertility benefits makes that now an essential health benefit. So it's a much more comprehensive list, but it's a very definitive list. It's no more, is this benefit in, is this benefit out? The question is this benefit offered as a part of that benchmark that was selected? If so, it is now an essential health benefit. Now, states might have to supplement these benchmarks to the extent that they don't hit those 10 categories. So, one of the things is pediatric vision coverage. To the extent that they pick one of these benchmarks and it doesn't offer any pediatric vision coverage, they will have to supplement that benchmark to pull in that element. What we're really going to end up with is more benefits characterized as essential health benefits. So any plan offered through the exchange or in the individual or small group market in that state will have to offer everything that is in that benchmark. And these benchmarks are being selected now. A lot of states have already selected them, and they will continue to be selected and publicized through 2014 when this requirement kicks in. Now remember, the rules are always different in the large group insurance market and for employer-sponsored health benefit plans. For those groups, the regulators are also moving towards a benchmark process. So remember, what we're doing here is determining what is an essential health benefit. And the reason why we're determining what is an essential health benefit is because you cannot place an annual or lifetime limit on that benefit. But you're not required to offer those benefits. It's only if you do so that you have to remove those limits. So for employers, all they've said at this time is you are going to have to select a benchmark. Unfortunately, what we don't know is, number one, when do you have to select that benchmark by? Are you still subject to the good faith interpretation standard now, or do you have to already select your benchmark? What I will say from that perspective is that even though the answer is not clear, we know that many of our clients aren't currently selecting benchmarks. So we're waiting for more guidance, because all the guidance that has come out to date, including this most recent guidance, doesn't address how this applies to self-funded employer-sponsored plans or insured plans offered in the large group market. The other thing we don't know is what are your options going to be? Do you only get to select the benchmarks in your state, or can you select the benchmarks in other states? Can you only select the benchmark that your state selected, or can you select from all the options that your state had, so from all 4 options? The other thing we don't know is what if you're an employer that sits in many locations? Do you have to select a different benchmark for each location, or can you select one based on something like your national headquarters or something to that effect? Again, a lot of unanswered questions there, and unfortunately, the regulators have really been pushing out regulations relating to how the exchanges are going to be set up, so they focused on that, but they haven't helped us out in terms of if you're an employer-sponsored group health plan, what you're supposed to do. So what we would say at this point is really just stay tuned, pay attention to this. I know we just had a question pop up that was, why are some states electing not to have an exchange? Now that is perhaps the most loaded question you can ask at a webinar like this, but I'll try and address it in short order. States are permitted to either set up their own exchange or have the federal government set up their exchange. If they choose not to do so, or if they just default to the federal government will come in and set up an exchange on their behalf. Now that is still a state-based exchange, but it is just operated by the federal government. So it would be like the state of, I'll use my state, so I'm not picking on any. The state of Illinois' exchange, which is operated by the federal government as opposed to operated by the state of Illinois. That's a bad example because I believe the state of Illinois is actually setting up its own exchange and operating it. You can also enter into a partnership where it's sort of half state, half federal government. But as we've seen, I think as of yesterday, 23 states have indicated that they are not going to set up their own exchange. They're going to default to the federal government, 23 states. So we're almost up to half of the states now. And there are a variety of reasons why states are doing this. I'll give you two perspectives from both ends of the political spectrum because it is a heated discussion, and I don't want to take one side or another. I'll just tell you what people are saying. A lot of the states that have chosen not to set up an exchange have said that they've either not been provided sufficient information from the federal government, or they think that the federal government is ultimately going to control the exchange anyway, so they're not going to even put themselves into the process. In other words, they don't know how to do it, or even if they know how to do it, they don't think that they're truly going to have control of this exchange, so they're going to let the federal government do it. Now, cost isn't really a driver here because the federal government gives large grants towards setting up the exchanges if the state chooses to set up the exchange. So those are the two factors given against setting up an exchange. Now, some more cynical have said that this is really just a political play because they don't want to participate in or endorse the Affordable Care Act. You know, the rationale here is that if you're doing it from a political perspective, though, typically that comes from Republican governors, and Republican governors generally favor more states' rights. But ironically, by giving up the right to the exchanges to the federal government, they are giving the federal government more control over their state. So it's a difficult political dance. You know, again, I'm not endorsing one way or another, but that's just how you've seen things develop on this front. So we already talked about this a little bit, but generally speaking, it's just a confusing situation for employers. States are selecting benchmarks now, but employers just don't know what they need to do. So stay tuned on that one, but probably sit tight. You know, we had another question that came in, and I want to address it now before we move on, that's asked about the private exchanges and whether those can replace the state or federal exchange. And the answer is no. Every state will have a state or federal exchange structured in compliance with and under the Affordable Care Act. There may be, on top of that, a supplemental private exchange, which is an exchange that is typically set up by insurers or insurance brokers that functions really similar to the state exchanges in that it's a marketplace with a lot of different options where individuals can go buy health insurance. There are a couple key differences, though. On the private exchanges, they aren't subject to these benchmark requirements. They're not subject to the essential health benefits requirements. So unless they are offering individual or small group coverage through that private exchange, they're free to structure the benefit package as they see fit. And what that means is that they're also not subject to the limits on who can go into a state and federal exchange. Now, state and federal exchanges, at the outset at least, are limited to individuals and small employers, less than 50 or less than 100, depending on your state. The private exchanges that I've seen set up so far have been structured to cover much larger populations. In fact, you've seen a couple of large employers nationwide say that we're going towards the private exchange model. And let me give you again, the pros and cons for the private exchanges. Many people have defined or described the private exchanges as a way to offer what is known as a defined contribution health plan option. And what that means is the employer is contributing a set amount of money, and that is their ultimate upside liability under the law. To the extent the employee incurs health benefit costs in excess of that, they don't have any additional liability. What it really means is that they're sponsoring a fully insured plan. So they're paying a set premium to the insurer, and to the extent that, and the insurer is paying out the benefits. So if the employee gets cancer, the insurer pays all that amount. The employer isn't required to pay anything except for their premium. So there's some benefits to that. Now, on the flip side, you know, there's a reason why employers self-fund, and the reason generally is they see some economies of scale. They have such a large employee population, they have a larger risk pool, and fewer the health benefit costs that are incurred are spread out over a larger population. So they really like that because they cut out all the administrative costs that are associated with going with an insured plan, and perhaps even the profit element that's tacked on top as well. That doesn't change, and nothing changes that in 2014. You might have a population that's getting more sick, which drives you to move towards more of a fully insured plan. But generally speaking, there would still probably be economies of scale of offering a self-funded health plan. Also, it's not truly a defined contribution health plan because you are going to have to index that to inflation each year. Because remember, if you don't pay enough of the health benefit cost for your employees, In these private exchanges, you're still setting up group health plans, so you're still setting up employer-sponsored health plans. But if you're not paying enough of the cost, you could be subject to the employer mandate. So again, that's kind of the pros and cons on the private exchanges and how those really work. But those are popping up right and left and will probably continue to do so. Okay, just running through a little bit more just for the employer plan sponsors in the room and for anybody else who's trying to structure their health plan. Again, if you are offering a plan that includes any essential health benefits, regardless of how that's defined now or in the future, you can't place any annual or lifetime, generally speaking, you can't place any annual or lifetime dollar limits on the amount of those benefits. And this includes a dollar limit on specific benefits. So you can't say, we have no overall annual cap, but you only can get $1,000 towards cancer treatment. You can't limit it in that respect to a specific benefit. So on the flip side, visit limits are permitted. So if you want to set a visit limit, you want to limit the number of times an employee can go to an acupuncture provider or a chiropractor provider during the year. You can do that. As long as it's not an annual dollar limit, that's okay. There is no distinction here for out-of-network versus in-network benefits, and this is a common misperception. A lot of people always say, well, that's fine, I'll remove my annual dollar limits for my in-network benefits, but anything out-of-network, I'm going to cap it. The regulators have made very clear that that's not the way they interpret the rule. In other words, they think that this rule applies across the board regardless of whether the benefits are offered in-network or out-of-network. And the other thing is that health reimbursement arrangements are a whole separate animal. And a health reimbursement arrangement is an employer-sponsored group health plan that is subject to these requirements. And the way that it works is an employer gives employees a notional bookkeeping credit into their account for a certain amount of money that can be used towards health benefit costs. Notional because the employers don't actually have to contribute money into an account. They just have a bookkeeping, a ledger, and when employees incur healthcare costs out of pocket, they can go seek reimbursement from their employer. The problem is, because you have a notional account, generally speaking, that's a cap in and of itself. In other words, employees can never incur health costs in excess of what is actually in their HRA balance. That is an annual limit, and the IRS has come back and said, to the extent you offer one of those and it is standalone, meaning you don't also offer in conjunction with major medical coverage, so your PPO or your HMO, you are prohibited from offering that type of arrangement because we see it as an annual cap. They actually did, though, implement a blanket exemption from now until 2014, but only for HRAs that existed before September 22nd of, I think, 2011. Starting in 2014, though, you can't have that standalone HRA. In other words, you have to either integrate it with medical coverage or eliminate it entirely and offer medical coverage if you're subject to the employer mandate. If you have a retiree-only plan, which is a discussion in and of itself, it's not subject to these rules. And I have to apologize. I know we just got a question, does this apply to open access plans? If the questioner could provide more clarification on what they mean specifically by an open access plan, what is that similar to, that would help out. Now, generally speaking, though, this applies to any group health plan. Now, a group health plan is a very broad term, but it is any employer-sponsored plan that offers medical benefits. There are accepted benefits that are not subject to these rules, and those are things like standalone dental and vision plans, most flexible spending accounts, workers' compensation arrangements. Things like that are considered accepted benefits and not subject to these requirements. But generally speaking, any major medical plan would be subject to these rules, and an HRA for these purposes is considered a major medical plan. All right, just a couple cautions here. And somebody else just also asked the question, will this make HRAs unattractive in 2014? I don't know. They might become less popular. They will definitely be unattractive if that's all you're offering, because that's a clear violation of the law and you're subject to a penalty of perhaps $100 per day per impacted employee. But to the extent an employer wants to sponsor a major medical plan accompanied with an HRA, that's still allowed, and a lot of people might still do that. HRAs are actually still very popular in the retiree-only context, too. And if you have a retiree-only plan, HRAs are still allowed. So, HRAs probably will still be allowed around, but to the extent that people were using this as the sole means of providing health coverage to their active employees, that won't fly anymore in 2014. So one thing to keep in mind is that if you combine a visit per year limit with a dollar per visit limit on the same benefit, that's going to add up to a dollar per year limit. That's prohibited because you can have a visit limit. That's fine. You can also have a dollar per visit limit because that's never going to cap the employee. Let's say you're going to give you $50 per chiropractic benefit. They can go 5 times to the chiropractor. They can go 100 times to the chiropractor. There's no ultimate upside cap. But once you combine the visit limit with the specific dollar limit on the benefit, on the visit limit, on the per visit limit, I'm sorry, I should say, that adds up to a annual limit. There's no way around it because you go 20 visits, capped at $50 each. That's a $1,000 annual limit. Okay, as I mentioned, they're generally not allowed, but they are phasing out. So in the short run, you can still have an annual dollar limit, but it has to be above these thresholds. And kicking off starting plans in 2013 for calendar year plans, it has to be no lower than $2 million. So a lot of people just got rid of these at the outset because these permitted limits were so low, so high, it didn't really help them any anyway. Starting in 2014, no annual limits at all on essential health benefits. Now remember, we're not talking about any benefit, we're just talking about essential health benefits, which is perhaps more confusing because, as we discussed, it's not entirely clear what is an essential health benefit, but hopefully we'll have more clarity in the very near future. Just one more caveat here. Until we get to this benchmarking process, it's difficult to determine what is a essential health benefit because even though you have something that doesn't fall specifically in that list of 10 items, something might cut across that. So you might say no infertility treatments because I don't see infertility treatments or anything like infertility treatments on the list. Even so, infertility treatments might involve hospitalization, prescription drugs, and laboratory tests, which are on that list of 10 items. So just be very careful when you're making this analysis of what is a good faith interpretation of essential health benefits. And remember, that analysis is being phased out, but that's what we're stuck with, we think, for the time being. Okay, so let's talk about cost. I've got a little bit of good news for you here. Let's talk about cost sharing limits. Now, there's a little known provision in the law that says non-grandfathered plans may not exceed certain limits or may not set cost sharing levels or limits at above a certain level. And I've got those limits specifically listed here. Now, these are indexed to inflation in subsequent years, but this would be where it would be if it were today. Now, at the outset, our concern was that everybody's ultimately going to become non-grandfathered. That's not entirely true. You could perhaps remain grandfathered for a long period of time, but if you don't make any prohibited changes. But generally speaking, everybody's probably going to make changes sooner or later that will cause their plan to lose grandfather status. So the question is, when you do lose grandfather status, are you subject to this rule? Let me tell you why this is important. A lot of people wanted to set limits on their plans at higher levels so that they could drive down the actuarial value. And it may be perplexing, but the reason why would be that they want to offer a plan that truly does just provide the minimum value, which we discussed above, so they can avoid the employer mandate, but nothing more, because they want to limit their out-of-pocket costs. The problem is it's very hard to design a plan that only provides 60% actuarial value if you're limited to these deductibles and cost-sharing levels that were just discussed on the previous slide. So the good news is, while it looked like this was going to apply across the board previously, clarification has indicated, the recent clarification has indicated that this is only going to apply to those plans offered on the exchanges and in the individual and small group market. Now, you're hearing that distinction again. It's the same breakdown for, those who plan have to offer essential health benefits. That only applies to plans in the exchanges and in the individual and small group markets. Same story here. And just to reiterate, exchanges are state-based, not private, state-based and federal-based exchanges. And the individual market is a policy issue just to an individual, not affiliated with a group. Small group market is generally, it's defined by state, but it's generally plans with under 50 lives or 100 lives, depending on which state you live in. All right, so let me just go back to this again so you see what those levels are. Now again, this is only marginally relevant. It's truly relevant if you're a small group plan, individual plan, or on the exchanges. But if you're a large group insured plan or a self-funded employer, the indication is that these limits won't apply. Now remember, you're still subject to that 60% minimum value rule, so keep that in mind. Now again, these are the 2012 limits. 2013 limits are already out, and they're a little higher for the out-of-pocket maximums there, but indexed to inflation. All right. One final topic. We say the best for last, or perhaps the worst for last. There are a lot, without a doubt, there are a lot of fees and, for lack of a better word, taxes associated with healthcare reform. and 2 of them are rolling out now, one now and one in 2014. And we just got guidance out on these 2 fees within the last week, telling sort of how they work and how much they are. And so let me run through quickly what this chart shows. Generally speaking, we're talking about here the PCORI fee, or the Patient-Centered Outcome Research Institute fee. We're also talking about the Transitional Reinsurance Program fee. Patient-centered, the PCORI is intended to fund research to help deliver effective health care. Now, your guess is as good as mine and what that means, but that's the stated reason for why they're raising this revenue. Transitional Reinsurance Program fee is intended to provide a reinsurance for those insurers who are offering coverage to individuals with pre-existing conditions. So these insurers are getting into the market of insuring individuals who are very high cost from a benefits perspective. So they're taxing people who don't provide those benefits to help offset the cost for the people who do provide the benefits. Now, the PCORI was the one that was everyone was worried about, but as you can see when you look at the cost here, the Transitional Reinsurance Program fee is actually significantly higher, $63 per covered life in the first year. The good news is that the Transitional Reinsurance Program fee runs over a shorter period of time, only 2014 to 2016, while the PCORI runs over a 6-year period. Both of these ultimately phase out, though. Now, stepping back a second, I guess, covered lives are generally defined as anybody who's enrolled in the plan. So you're talking about employees plus dependents. There are a number of different ways you can calculate the covered lives on your plan. You can look at the Form 5500 and modify it accordingly, because that doesn't pick up covered lives. But the point here is that there are pre-approved methods for calculating how many people are covered under your plan. Somebody asked here, are the federal employee health benefit plans exempt from the PCORI fee? You know, it would depend on how those plans are characterized. Generally speaking, the PCORI applies to group health plans and group insured health plans and plans on the individual market. Off the top of my head, I'm not really sure how a federal employee health benefit plan is characterized, but it may in fact fall within one of these criteria and be subject to this tax. And you know, now that I think about it more, I seem to recall that there are special rules, especially under the PCORI, for governmental agencies. So I think that the answer is tentatively yes, federal employee health benefit plans is subject to these rules, but there are special ways that it applies. And don't quote me on that, because again, we can confirm that and get back to you on it. Important part, but perhaps not quite as important as you might hope, is who actually pays the fee, who's liable here. In the insured context, the fee is always paid by the insurer. In the self-funded context, it's paid by the plan sponsor, which for the most part is the employer. That's under the PCORI, but under the Transitional Reinsurance Program fee, it's actually paid for self-funded plans. It's paid by the third-party administrator on behalf of the plan sponsor. Now that sounds great, but what we've recently learned is that the ultimate liability flows back to the employer. Otherwise, the third-party administrator would sort of get out of the game there. So the long and short is that regardless of who pays for these taxes, they're probably ultimately going to flow back through to the plan, the employer plan sponsor, to the extent there is an employer plan sponsor. And one final question here is what types of plans are exempt. You know, this gets back to the whole analysis of what is a group health plan. Generally speaking, it would be any major medical coverage. It would be an HRA. That being said, certain group health plans, sometimes EAPs, employee assistance plans that help provide employees with emotional counseling, disease management programs, and wellness programs are typically considered group health plans because they provide some sort of medical benefit. But here they've said that they will be exempt if they only provide very limited medical benefits. Now that's sort of a hazy term, but our takeaway is that unless it's a full-fledged major medical plan, you're probably not subject to that requirement. Retiree-only plans are not exempt. Now, retiree-only plans are exempt from a lot of requirements under the law, but this is not one of them. So if you have a retiree-only plan, it is still subject to this fee. And to the extent that you do have something like an HRA, the extent that HRA is bundled with a major medical plan, you're only going to get hit once with this tax. So just something to keep in mind there. Now, I think that that's all very high level. And, you know, I know that Cypher Shaw does have alerts on their website that discuss these in much greater detail, and we continue to issue alerts as new things come out. But that's just something to keep in mind, is that these are just the very high-level overview of the new requirements. Unfortunately, there's a lot more coming out before the end of the year, so stay tuned. And with that, I'm going to kick it back to Jonathan.
Thanks, Ben. That was extremely informative. Definitely appreciate that insight. For those of you who would like to keep on getting updates regarding healthcare reform, you can sign up for our newsletter at Employer Healthcare Congress. For those of you that are looking to get certified in person, if you don't want to do it online also, that'll be available starting November 3rd through the 5th, 2013 in Las Vegas. And going forward in the future, some of our special updates and webinars are going to be available just for those who are actually going through certification as a benefit to keep them educated and give them a step ahead of the rest. If anybody has any questions, we received hundreds of questions on this webinar. Unfortunately, we don't have time to answer them all, but we're going to take it over to social media and to our LinkedIn group. So there's a link here for Join the Conversation. We have a Healthcare Reform LinkedIn group with over 13,000 members. We've already started a discussion group for anyone on the call to ask their questions, and we will respond to the answers. You can email me at John@Employer Healthcare Congress or Ben at bconley@scifarth.com. And we hope to see you posting questions on the group where we'll be providing answers. The webinar will also be available tomorrow for anyone who missed it or would like to watch it again, and we will post that link in the discussion on the LinkedIn group. Thank you very much for joining you, and look forward to seeing you on the next webinar. Take care.